Mic'd? Yes. Great. I hate lecterns because I'm very short and I usually end up peering over the top of it unless I carry around a little box. The Secretary General, Antonio Guterres, is even shorter than me. And he has a platform bearer, a person who walks around with him with a little box and puts it down so that he can stand on it. It's great to be here again. I spoke last at RMA here in Darwin in 2018, and at that time I was still working for the UN. And it's really lovely to be back. It's nice to be back in Australia. I left New York when Australia announced that it was closing the borders, and I had literally 16 hours to pack up a life of 7.5 years to get on the last plane that came back to Australia. So it was like, whew, and I got a sense of what life must be like for people fleeing from war and violence. I acknowledge the traditional custodians of this country, the Larrakia people. And I acknowledge that our history in Australia is one that has created wealth for many of us at the expense of those traditional custodians who held this land for many thousands of years before we got here. And I don't only pay tribute to their elders, but I also pay tribute to their resilience, to the amazing resilience of Indigenous Australians and to the resilience of Indigenous doctors in Australia who go to work and continue to serve their own communities and others in the face of all of the challenges that encompasses in Australia today. So I thought in that context it would be appropriate to also just acknowledge our artwork. It's easy to skip over it and not explain what the artwork is. So you'll see it pop up on a few of my slides, and it symbolises the coming together of people to solve problems, which is the 5 people around in the middle. The healing happening in the middle, which what looks like the sparkly sky, and then the waves of impact spreading out. And I hope that that's going to be our future. I'm not sure about that yet, but that is the vision of the artwork that was created for us. A better culture, some of you may already have heard of it. I've certainly been doing the rounds, talking to conferences, talking to government, talking to various colleges, and thank you very much to ACRM and RDAA for the invitation to be here today. I am still working clinically. I pay tribute to my colleagues from Cape Coast who helped me get my clinical footing back when I was a bit rusty. I know you're out there somewhere, so thank you. There you go. And so we're funded by the Commonwealth through the repurposing of funds from the Specialist Training Program for RACMA. So it's a real partnership. And I thought I would spend a little bit of time talking about the journey to here, because I'm a bit of an oddbod, because I've had some very different experiences to many people who follow a traditional pathway. And maybe some of you who are taking the road less travelled will draw some encouragement from this. So my first step off the traditional pathway was to become the Student Union President at the University of Queensland after my 3rd year of medical school, because med school wasn't hard enough. I just needed to take on something else. And that was actually a full-time salaried position. And part of my role there was to represent students of all the disciplines, not just medicine, but to represent people who were facing exclusion from university. And I came face to face with the different attitudes towards mental health and disability that were applied to medical students versus the other students. It was my very first wake-up call that there was something rotten in this place. And then when I was a junior doctor, and I think this is an experience many of you will have, year on year, for at least 10 years after I graduated, one member of my graduating class committed suicide, year on year. And then I started work for the medical board, and with that background behind me, I set up a thing called the Health Assessment and Monitoring Program, which was a regulatory program that was designed to manage the clinical practice risks around doctors with mental and physical impairment. But one of the things we managed to do during my tenure there was to turn it into a program that supported reintegration and rehabilitation rather than just punishment, stigma and shame. And for a while I worked for Medicare, and it's the only job I've ever had in a regulatory role where a spouse rang me up and thanked me for intervening. I got a phone call from a rural doctor's wife who said, "Thank you so much for coming out and telling my husband to stop." because he'd got onto this treadmill of just so much work and so much claiming. So I've seen plenty of different sides of how the system works. And then I worked for a while in patient safety, and one of the things I learned was, the health of the clinician has direct impacts on the health of their community and the health of their patients and how well they can perform. It's very obvious, and it kind of links back to that role that I had with the medical board, but we don't give it the priority overall that we should, and certainly health systems don't. So then I trotted off to the UN, and that was a real eye-opener for me because, as was mentioned, I was actually in charge of the occupational health and safety of the entire UN workforce, not just the medical workforce. And the thing about the UN is that when you're a doctor, you don't get treated any different to the rest of the workforce. It was the same stuff. So we had to jump through the same hoops of proving our fitness for the job that we had been hired to do, the same sick leave provisions, the same fitness to work, the same preventive activities, the same vaccination requirements. There was absolutely nothing special about how doctors in the UN were treated as employees. And that was a very interesting and from my point of view, a very positive experience. Then I came back to Queensland Health, and I joined Queensland Health in the middle of the COVID outbreak. And I was smacked in the face by the fact that they didn't have, to the best of my awareness, an occupational health and safety physician, like an occupational physician on the staff, doing all the stuff for the staff that I had been doing for the staff of the UN during the UN outbreak. It was just missing. And there was this almost magical belief that the doctors would sort it out for themselves because they're doctors and they know doctor stuff and they'll do doctor things and everything will be okay. And that included being protected by the magic curtains in emergency rooms. You've all seen those, haven't you? The magic blue curtains that stop people catching respiratory diseases, they're great. And of course, the absence of PPE for those of us who were working in general practice at that time, it was BYO, and I had a little string of recycling. I worked out that the best place to re-sterilise them was to hang them in my car in the sun, so that my recycled N95 masks got pasteurised. So, you know, I experienced some real differences, and I came to the conclusion there that we've really got to do much better as a profession at understanding that we are human, that our health is important, not just to us and our families, but our health is important to our patients, and we shouldn't have to link it to outcomes for patients, but unfortunately it seems that that is the only way we can make the business case. So then, after I left Queensland Health and returned to the clinical front lines during the opening of the borders, I got offered this gig at RMA, which was really responding to the medical training survey. And let me take you through some data. 42,000 doctors in training responded, 42,000 surveyed, 4% responded, and 3,247 of them were IMGs, but I love RT's terminology of Australian doctors trained overseas. I think that's a really good term. And then 176 respondents were Aboriginal Torres Strait Islanders. So in that cohort, this is the standard data, and this is what comes out in the standard reports, that 12% experienced bullying, 9% harassment and racism. Now that tells one story, doesn't it? That tells a story. But let's start by doing the most fundamental thing that epidemiology and demography tells us to do. Let's gender disaggregate it. So you compare the women to the overall, and it doesn't look like they're much worse off, does it? But if you compare the women to the men, goodness me, look at that gap. So the experience of female trainees in Australia is significantly worse than the experience of male trainees in Australia. And I wonder if that has any connection at all to the worst mental health outcomes for women in medicine in Australia. And if you look even further and go to the non-binary population, the experiences are even worse again. Now, to their credit, I did a breakdown like this at a presentation that the president of the board was at. I sent her my data, and the board subsequently published a full gender report. First time they've ever published gender disaggregated data. So that's one of the things that they might have already been working on it, but I'm going to claim it as a win. And then, of course, let's talk about race. So Aboriginal Torres Strait Islander doctors, absolutely blow the chart apart. You have to rescale the chart to be able to chart the experience of Aboriginal and Torres Strait Islanders. I don't know if how many of you were here when I was here last in 2018? And yeah, okay, there are some of you. I don't know if you know, there were a couple of really significant things happened for me at that meeting. The first one, it was during a Q&A session and someone asked a question and I took a deep breath and I said, "It is my personal view that Australia remains a deeply racist country." And I was very nervous about saying that. Why was I nervous? Because I wasn't there just as me, I was representing the UN. So that was actually a pretty big call to make. And I did work and ACRM were great at helping with the subsequent media and making sure that we stressed that this was Jillann Farmer's personal view. I wasn't there as a special rapporteur on racism on behalf of the UN. But it was big also because I think it was the first time I'd ever said that in an Australian audience, and that's a hard message. And I didn't have any data to back it up. It was just a subjective thing that I felt. And it was actually, a lot of it was based on my personal journey of coming to terms with my own racism, which I had been utterly oblivious to before I went to work at the UN. And I realised that I had been incubated in a pot that created me. And I think that we share accountability with one another for the types of people we create. So when you put gender and race in there, you can see that things are a lot worse for some groups than they are if you just look at the general report. So let's look at ACRM and RACGP. And this isn't a competition, okay? I'm not aiming to say anything, but there is some data here that's really worth looking at. So 546 ACRM respondents, 2,700 RACGP respondents, a little bit of a difference in gender proportions, a little bit of a difference in Aboriginal Torres Strait Islander proportion, but probably because of the overall numbers, there would have been a greater all N number of Aboriginal Torres Strait Islanders for the RACGP. And then a breakdown that shows you the IMG status. So 35% trained outside of Australia and New Zealand for their first degree for ACRM and 51% for the RACGP. So let's look at some data. So this is the comparing RACGP and ACRM women to general practice overall. Sorry, to the population cohort overall. So RACGP slightly better on most of them, ACRM quite a bit worse for the women. Let's look at the men. RACGP roughly on par overall, but for the women in the bullying domain, significantly worse. Otherwise, not a whole pile of difference. Okay. So when you put all that together, it is the experience of women in ACRM's training program that throws up a flag to me. And there are many potential explanations. I'm not pretending to be able to explain this, but I'm putting it for you for reflection and consideration. So let's talk a little bit about privilege. Now, some of you have seen me talk about this before, and it's great when people come and tell me that something I've said is useful to them. I've had feedback that this is useful, because oftentimes I find that particularly my white male colleagues can feel really attacked when we start talking about privilege, and I want to stop that. You cannot help it if you're privileged. It just is. It's like the colour of your eyes. Or the colour of your skin. It is something you really cannot change. What you can change is what you do with it. So privilege is not, at a personal level, either good or bad. And it's not the same. To say that you are privileged is not the same as saying you are racist or fascist or misogynist or homophobic. It just is. So if you happen to be educated and wealthy and have white skin and be skinny and any of those other traits that are on there, the world treats you better. That's just an established fact from the research. It doesn't make you a bad person. Where it can be a little confronting is perhaps reflecting that some of your success has come about because of that privilege. And that's where it can get uncomfortable and we want to turn our faces away. So privilege is about the dominant social paradigms, and historically that has been white, Christian, male, English speaking if you're from the colonial countries. There is sort of a recipe to what privilege is, and it can be confronting if you look at that wheel of mine and see that you are at the centre of the wheel. And I've had people, after I do this, a talk like this, become quite concerned about it, but you don't have to be concerned. Let me just say that to you. Because privilege at the personal level, it's about what you do, and that's why I'm out here talking about it, because I have privilege. I can say stuff, and even in my own clinical work, sometimes international colleagues will say to me, there are things you can say that I can't. Will you say this for me? Think about that. That is a direct manifestation of some of the racism that people endure. So I can get up and I can talk about racism much more easily than Sarah Jane, who's the Aboriginal Torres Strait Islander Senior Medical Officer who works in our team. She has said that to me. She said, you, Jillann, you can say the racism word and not get the blowback that I get. So I try to flex that privilege that I have as an educated, Australian-born, white woman. Yep, I've got some areas of disprivilege, but I've got a heck of a lot more privilege than many of my colleagues. So unconscious bias and privilege go together, and that's a linkage that we often don't make, but I had to make when I was working for the UN, because if you come from a place of privilege, you actually think that everything is easy for everybody because it was easy for you. I went through this. I remember being utterly flummoxed as to why some of my patients who I could see were smart and articulate and, you know, utterly brilliant, why were they not going off to medical school and, you know, doing great things? And over the years, I've gained a little bit of wisdom, and I understand that there are things that get in the way. And when you occupy a position of unconscious privilege, and that's really, I think, one of the things I would like to say, is that becoming conscious of your privilege actually puts an amazing tool in your hands. It's nothing to be ashamed of. You should be ashamed if you use your privilege to enrich yourself and your family at the expense of others. That is not the correct or righteous use of privilege. But when you use privilege as a tool to do good, it's a powerful thing and something to be proud of. If you've never done it, have a crack at the Harvard Implicit Association Test. You can run it for different types of unconscious bias. You can look at whether you have an unconscious bias about race or about gender or about a number of other things. And there is a version on that site that's been validated for Australia. So if you've never done it and you'd like to do some reflection in this space, go ahead. So I'm very grateful to have been in the session sponsored by Monash's sexual assault education program, because one of the things that I've been actively campaigning around is sexual harassment. Up until this year, the medical training survey never had a question about sexual harassment. Never. It was just bundled in with harassment, and from my point of view, that equated to the silencing of the survivors. So 10 years ago, The Guardian published this. 8 years ago, The Guardian published this. 4 years ago, The Guardian published this. A year ago, The Guardian published this. And finally, in 2024, after some fairly public terse words from me and I think some others as well, and perhaps because they had been thinking about it for so long, to their credit, the medical board has included questions about sexual harassment in the most recent training survey, and I look forward to seeing the results, and I hope that over time people develop the trust to be able to report honestly in that survey so that we can fully understand the nature of the beast. And again, this is just this year, I think, underreporting of sexual harm. So it's out there, the public know it, but as a profession we've not been talking about it, and we're going to start talking. And for those of you who are sitting here now saying, what is she talking about? Like, sexual harassment isn't a thing in medicine, racism isn't a thing in medicine. Just stop for a minute and think about, why might that perception not be right? What is it? How is it possible that you might not know this? I worked with someone for nearly 10 years, and then one day I told them that I was a survivor of sexual assault. That person had no idea before then, because I just hadn't shared it. There'd never been a time when it was relevant or meaningful to put that on the table. And so you simply don't know what's been happening to colleagues if you never have a reason to discuss it with them. So during our work at a better culture, one of the first things we did was to get a company to interview a whole pile of senior healthcare managers. And one of the things that disturbed me in this report was a claim by the senior managers that doctors were never racist to other doctors. And I just thought, what planet are you guys living on? So anyway, even though we commissioned the report, we then went to develop the counter-narrative. And so we asked our fabulous reference groups, of which I know that there are members in the audience, we asked some of the members of our reference groups to share stories with us that we could share with you. And I'll give you a moment to read these because they deserve to be treated with respect. And this one particularly backs up Jenny's earlier plea that we find the strengths of IMGs, of Australian doctors trained overseas, and look at what those strengths, that knowledge that they have from their own systems, can bring in. I'm always amazed at how many people say Australia has the best healthcare system in the world, and then when I ask them how many of you ever worked in another healthcare system, nah. So we're very good at adopting the political rhetoric of the day. So let's talk about a little bit more about perspectives. So this one's just about bullying, harassment and discrimination being tolerated. So just look at the combination of the purple and blue bars. This is the number that agree that that's the case. So for the RACGP, it's 88%. For the ACRIM, it's 83%. But if you segment out Aboriginal Torres Strait Islanders, it's only 64%. So there is that again, that thing that you don't always know what other people are experiencing, or it might happen under your nose and you're not recognising it for what it is. Because when the arrow hits you and it's a well-targeted arrow, you might feel it, but others won't see it. And I don't want to be party political. This is just an example, okay? John Howard was the Prime Minister of Australia, and one of his great achievements was getting guns out of this country, and having lived in the US, I think that was an amazing achievement for which I will forever be grateful. But he epitomises the person who doesn't understand that his privileged existence does not define the existence of all of Australia in all of its diversity. And that becomes a problem when a person in a position of privilege seeks to negate the experience of a person who's had a different experience to them. So if someone comes to you and says, so-and-so is sexually harassing me, well, that hasn't been my experience. If you're a bloke, it's probably not going to be. If you're an older woman, it might not be. If you're not gay and they are, it might not be. So listen when people tell you something, and think about why your experience might be different from their own. And that's really what I believe the phrase that gets so misused, called check your privilege, it's spat out as an insult. If someone comes to you with a statement or a report or feedback that challenges your perception of the environment you're in, just stop for a moment and ask yourself, what is it about my space that means I haven't seen this before? Don't immediately doubt them because you haven't experienced it yourself. That would be one thing that I would hope you can take away from this today. So let's just quickly now go to the approach that we're taking at A Better Culture. So you'll hear lots of words around, and I've been out on the campaign trail now for nearly 2 years, bad-mouthing wellness programs. And I'm really pleased to say that this week, Harvard Business Review published something saying, will you all stop it already with the wellness programs? And I'm so grateful that finally the good folks at Harvard have listened to me. So, but our national health and safety regulator has actually put a statement out on this, that workplace health and safety is about preventing harm at work. That's actually a really important difference. And it is one of the reasons why I was so smacked in the face when I got back in the middle of a COVID outbreak and discovered that workplace health and safety wasn't front and centre. How do we stop our clinicians getting infected at work? Because in the United States, where I had come from, clinicians were dying. You know, the US lost many thousands of healthcare workers through COVID. And it just felt really weird coming into this environment where workplace health and safety wasn't at the front and centre, but we all had muffins and yoga days and yes, yes, yes. So Safe Work Australia is publishing a model code of practice, and they've got that on psychological safety at the moment. If you are an employer, and even if you're a supervisor, you're still a PCBU, and it's worth having a look at. Person conducting a business or undertaking, and you have certain responsibilities under the legislation. This is a lovely conceptual toolkit, again, very hot out of the literature from a UK group. And what I love here is that they've actually developed a typology for all of these programs. And I don't think the laser pointer will work on the screen. Nope, I've just gone there. Let me see if this works. No, I don't think it does. The big circle at the bottom right, the big circle, not the key, that's about redesigning workplace. That's about preventive actions. That's about stopping the things that harm people. The middle circle is about increasing people's resistance to harm. So that is where your resilience programs come in. But you've got to be careful with those because, as was just demonstrated by the laughter, the muffins and yoga and stuff really increases workforce cynicism, and we experienced this at the UN. We were dealing with staff who are in much, much more stressful environments than you can imagine. You know, I've been in a situation where the bombs are dropping around me, and you know, if you give people resilience training in that environment, it's, you know, like, really? So we had to rethink our approach there as well. So as I've just mentioned, a person conducting a business or undertaking has to ensure that the people that they're responsible for are not harmed. And one of the things that I have been saying is that based on those suicide figures, based on the mental health outcomes, based on the levels of burnout, I sometimes think that if healthcare was a mine, we would be shut down. You know? And so let's start talking about workplace health and safety. Let's stop talking about wellness and well-being. Let's claim the rights that the law gives us. We have a right to be safe at work. And that's kind of challenging because there's this, you know, this historical mythology of the self-sacrificing doctor who will put themselves at significant harm all the time. You know, now I seriously gave thought to joining a mission to another war zone recently. That's a different thing when you step into the risk and it's a short-term thing and everything that can be done is being done. But to be chronically exposed to unmanaged risks that people will ignore on the basis that they know you'll keep going from a sense of goodwill, that's not good enough. So you might have wondered what our little X+ logo is about. It's about bringing together more and less. We're not about individual resilience, we're not a doctor's health program, but we do want to challenge that perceived locus of control, that healthcare historically has seemed to think everything would be all right if the staff were just strong enough. And that's just not true. Healthcare requires a system response. And so we want more emphasis on occupational health and safety, more emphasis on the drivers and enablers, more emphasis on hard levers for change, and more collaboration. And yes, occupational health and safety. My very own word, and I might patent or I trademark it. So our body of work encompasses setting some expectations, which will be around individuals and employers. We've got curriculum coming out to develop up training. We've got a focus on cultural safety, which is different to the standard cultural safety training because we've identified that very few products are focusing on the cultural safety of employees. It's all about the patients. And so what we see is people go off and do the training about the patients and then go to the tea room and start making horrible racist comments beside their colleague who may or may not have identified with them as being a First Nations person. And so cultural safety of colleagues is one of the things that will start to address that very big bar that you saw on the graphs. I'm going to skip through these just so if you are interested in more detail, you can visit our website. I think the things that we can do is just be sensitive. I think the big thing is understand that everybody else's experience isn't the same as your own. And that's, for me, that was a really big learning. And then start looking out for microaggressions. I did an emergency intervention in a workplace a couple of weeks ago when someone was sitting at the bench surrounded by junior doctors on a homophobic rant. And I just, bang, stopped it. No, this conversation has to stop. Stop, stop, stop. And I had to stop. I mean, I had to really work hard to stop that conversation, but I did. And I subsequently learned that there was a person in that workplace who was gay and was feeling really unsafe. So don't assume that behaviours are safe just because you think you know the audience. I'm always inspired by this very brave woman, a black American woman in the South in Mississippi. And she was one of the leaders for getting the Democratic Party, which we now all think of as being a fairly left-wing party. But they were segregated in the South so that there was a black Democrats and white Democrats, and Fannie Lou Hamer got them together. And she was one of the first people to enunciate the principles of intersectionality. So I try very hard to use the wheel in my daily thinking and when I'm attacking problems, because one of the things I had to come to terms with, just as I've challenged some of you today, one of the things I had to come to terms with, that for many marginalised communities, white women are now seen as a problem. Yeah, because we suck the oxygen out of the air in discussions of equity because we want to make it all about us. And in fact, people who experience intersectional disprivilege can be pushed aside. So it really, that's why I like that tool. I reproduce it a lot. It's not my own. I've heard people have developed modified versions of it. Knock yourselves out. I do think it requires a rurality and remoteness thing on it, working in an MM3 area as I do at the moment. But I want you to go away from here not feeling attacked for your privilege, but go away feeling that this means you can do something. And it was never my intent to attack people and make them feel bad about being born who they were. It is beyond our control. It's not just me. I have a great team of people behind me. Sarah Jane is our Aboriginal Torres Strait Islander Senior Medical Advisor. Komal, Maddie and Jade make it all happen. We've got reference groups, of which I know there are some members here. Working groups, you can see the chairs there. I'm not sure if Nicole is here. I saw her at the breakfast this morning, but Nicole's is a member of our advisory board and has been chairing one of the working groups. And Dr. Lewis Peachy, who's a bit of a legend, and we're very, very, very privileged to have him with us. And that's the advisory board, and that's my acknowledgement slide, both to the Commonwealth Department and to RMA. Thank you.
Thanks, Jillann. Really important stuff. A question from Trish Murphy is, are the data going to be available for referencing, or is this talk going to be available? And are you willing to share that on the website? That would be great. Okay, so we'll do that and we'll let people know how that's going to happen. I just want to talk about the gap between doing the stuff, which is about training, and the behaviour. So this has been an enormous issue in the ABC, as you've probably read.
Yes.
Enormous. And so we all go through training programs right across the organisation. We do the cultural safety stuff. And not much has changed, I would say, within the ABC. Certainly when you talk to the people who are experiencing the behaviours that you're talking about, they don't think things have changed. So you go through all this. How do you get meaningful change?
Yeah, so we did a session just 2 weeks ago at the RMA conference where Sarah Jane, who was supposed to be joining us here but has been unable to come. Sarah Jane ran a session for the medical managers of Australia, like medical leaders, called From Compliance to Commitment. And I think it is actually about leadership, and we asked some really compelling questions during that. One of them was, how long do you think the behaviour change lasts? And the overall answer was about 6 weeks, if at all. And the next two questions were, has cultural safety ever come up in your own performance agreement? No. Has cultural safety of your staff ever come up in your own performance agreement? And no. So I am of the view that it's about leadership commitment, And if we're going to train people in cultural safety but never have anything about cultural safety as a KPI or something that leaders have to deliver on, then that turns it into a compliance activity where people go along, yeah, it's like your fire training. I did my fire training for the 75th year. So that's one thing. And then the other thing that we're doing in the curriculum space is developing a continuum of curriculum so that you're not going to go back and do the same training year on year on year on year to introduce progressively more sophisticated concepts. I do believe it's about organisational commitment. And, you know, it's the same with gender equity. We can have all the policies we like, but until Antonio Guterres, for instance, joined the UN, to atone for the sin of being a male whilst Secretary General, because he was supposed to be a woman that year, within 6 months, half his cabinet were women. And so it's leadership commitment makes all the difference. And I believe we will see change when we see leaders from their positions of privilege start making this a main game and not a compliance activity.
I mean, it strikes me also as it goes to safety culture, which you're talking about, patient safety culture. So one of the core issues, one of the core things about patient safety is everybody should be able to speak up on the team when they see something going wrong, and which is applying what happens in the, in the airline industry to medicine. And there'll be plenty of junior doctors in this room who don't feel able to speak up even now. But what you're talking about does require people to speak up. And when you're not, so you're talking about privilege, I want to talk about power. So how do you speak truth to power when you are the junior here? And,
There's two,
and the system.
Thank you so much, Norman, because I skipped across something in one of the slides. So Sarah Jane couldn't come, so she had a session this afternoon at 4:30 that was going to be a bit of a program overview with Indigenous emphasis. I can't do that legitimately, so I've redesigned the session to be about safe reporting pathways. So if people want to come along and give me information and data about safe reporting pathways, have a look for that session this afternoon. There's a couple of things I would add.
Can I just interrupt there?
Yeah.
So it's fine to have a reporting pathway, so you can play, but safety is actually, you know, you are my senior, and I can say to your face, that's not right, and my career will not suffer. I mean, it's more than, that immediate response is going to get changed.
It's about having a safe reporting and a safe responding pathway, which is going to require a whole lot of collaboration. The medical training survey identified a really big discrepancy between what trainees thought they would do if they had a matter that needed reporting and what they actually did when the crunch came. And we want to explore that gap. So something like 70 or 80% of them said, yes, I know how to report and I would report, but when something happened, only about 30% of them did, for exactly the reasons that you're talking about. So it is going to require system change, it's going to require sometimes pathways, probably nearly always pathways that bypass their immediate boss and create a space where they can speak truth and be heard without putting things at risk. The other thing I would say, and I have done this myself, so I know how hard it is, when I was a medical student, there was a surgeon was attacking one of my colleagues who had been was at that time, still I think on a refugee visa, as a young Vietnamese woman. And he was attacking her because she didn't recognise a quote out of the Bible. She was Buddhist. And I knew I didn't want to be a surgeon. I knew that I could crash and burn in that moment and it wouldn't matter, so I had power. You don't always have power, but in that moment I had power. So I remember I put myself in between him and her and I said, and would you like to enlighten us with a quote from the Book of Buddha, sir? And the attack stopped. So sometimes, Norman, when you see that happening, it's about recognising if you have power to do something about it. And we are going to be including modules about becoming an upstander in our training, about being an upstander. How do you safely do that when you see someone who has less privilege than you under the hammer?
And just finally, I want to know about the crossover with clinical governance, which comes back to my previous question. If you've got a system where a junior person can't speak up about what they see as racism, discrimination, sexual harassment, is it a system where they can't speak up when something's going wrong in the clinical? You've seen an error and you want to call out that error. So in other words, is a workplace in healthcare where you can't speak up about discrimination in all its forms a safe clinical workplace?
Probably not, but I would say that doctors historically are much more willing to speak up on behalf of their patients than themselves. So I've seen that time and time again where people will take a risk for themselves if they really think patient safety. And I've had engagements with incredibly courageous registrars, for example, reporting utter misconduct clinically from their senior colleagues. I think it's harder when you're the beneficiary. I think that's a much tougher thing to do, to have that courage and to put something out when you go, well, it's just me and I can make the decision, so I won't speak up.
Please thank Jillann.
Thank you. Thank you.